permanent pacemaker inserted for severe bradycardia about 4-5 years back, referred to us for sudden onset of shortness of breath. This is the ECG. What do you all see here? What is striking? Oh, look. Is the rate regular?
Yeah.
Regular tadi?
Yes.
Regular, yeah? QRS seems a bit wide, do you think? Right?
Yeah.
The S wave, the R wave, everywhere seems very bizarre, right? What do you think is going on here? Is this a particular morphology that you all have seen of before? Anyone can shout the answer? No? Not a good ECG then, huh? Okay. Let me speak about the conduction system of the heart. So, what is the pacemaker of the heart? Where is the pacemaker of the heart? It is the SA node, okay? So, SA node conducts to the AV node, to the bundle of his, left bundle, and right bundle. So, I'm speaking about bundles. So, what do you think the ECG is about? LBBB, yes, thank you, Dr. Shakir. So, have a look here. So, AV node, RBBB, LBBB. AV node, RBBB, LBBB. So, what happens is, conduction system usually goes from the left side of the heart to the right. Okay, this is how it goes, this direction. Okay, so the thing is, what happens when the left bundle branch is blocked? The RBBB is the one that conducts first. Eventually, the right side of the heart conduct. Then via the septum, the left side of the heart will start conducting. So instead of the left to right depolarization, it becomes a right to left depolarization. This will in turn cause a few changes. So usually what happens is there will be a Q wave over lateral leads because the depolarization is coming away from the lateral leads. So when that is lost, eventually you lose the Q wave over the lateral leads. So this is what I was speaking about now. So the R wave, you get a tall R wave over lateral leads 1, V5 to V6. And you get a deep S wave over the right precordial leads, which is V1 to V3, and most of the time you get a left axis deviation also. Oh, yeah. And not forgetting the M-shaped R wave that you all see. Remember the William, whatever you all remember it of? So, UC and LBBB. What do you do next? Patient give me a shortness of breath, maybe a bit of chest pain. You look for the criteria. Those who know what criteria it is, it rhymes with samosa. What is this? Scabosa. Great. So, Scabosa criteria, you must remember the moment the points is 3 and above, you will treat it as if it's an acute myocardial infarction. Okay? So, let's say the first criteria is already fulfilled. So, ST elevation more than 1 mm, this thing over here, in a lead with positive QRS. So, QRS pointing upwards, and there's ST elevation upwards, the same direction. This will produce 5 points. If there's ST depression, this one over here, ST depression 1 mm in lead, V1 to V3, you get 3 points. If there's ST elevation in a disconcordant QRS complex, what does this mean? You look at the QRS, where it's going? Downwards. ST elevation, upwards. Opposite, right? You have this, you get 2 points. The moment you get 3 points and above, it confers 90% specificity. And this is, you'll treat it as if it is the ST elevation MI. Treatment will still be similar. So, we go to the L in elevation. This is left bundle branch block. So another scenario, 55 years old gentleman with end-stage renal failure missed the hemodialysis because we lodged in our HT center for 2 weeks. Subsequently, there was no financial income for him to support his own dialysis. Came in with palpitation, lethargic. You did an ECG, and you see this. You don't see anything. Yes, of course, we will dialyze first and go to our nephro counterparts. So, have a look at this. What do you all see? T wave? Yes, very, very tall T wave. And most of the leads. So, what do you think? Spot diagnosis is? Come on. Hyperkalemia. Yes. So, what do you do? Oh, yeah, okay. Yeah, we can put a rear end there. If it touches you and it's painful, it's hyperkalemia true also. So, what do you do in this case? Let's say if this patient is not, on regular dialysis, anyone comes with this kind of ECG, and eventually you get a potassium high Maybe about 6.5. What do you do?
Lactic cocktail.
Lactic cocktail. Favorite, huh? So of course, so you give lactic cocktail, and subsequently you get an ECG like this. Here dia. So spot diagnosis tak? Betul? Betul lah, hyperkalemia. Came back to sinus rhythm. So just what they always say is, if you read books, they say the height of your T wave is supposed to be less than 50% of your QRS. Okay, but this is not always true, because sometimes even if it's a bit on the high side, this could be a normal variant. So I'll show you some images. Have a look at this. This is hyperkalemia, this is a normal variant. What's the difference? This looks like a tent. This looks like a very weird tent. Correct. Look at this. It's as if this T wave is actually pinched from the sides. It looks like a proper tent. It looks like a tent that you want to live in, right? Not a tent that's like this. You look at this normal variant, it's asymmetrical, not like Aishwarya Rai. Correct. So you see it goes up slowly, then there is a steep that's going down. This could be a normal variant. Of course, with your clinical features, manifestation, all that you put together and you come up with a diagnosis. So if you get this tall tented T wave, which is symmetrical with a narrow base, this is hyperkalemia, antiproven otherwise. But they can also come with a lot of other things. Tall tented T wave, loss of P waves, you get your white QRS, sine wave, and patient cure. So the E, which is electrolyte imbalance and mainly hyperkalemia. Okay? So another ECG that I want to give you. So 45 years old lady, history of angioplasty done just 2 years back, came in with epigastric discomfort. As usual, epigastric discomfort, but patient has had angioplasty done. But angioplasty done what? So trace ACS. No, ECG is like this. What do you think is wrong here? Have a look at the ECG. Anybody want to volunteer? Talking a lot today. Come on, guys. Interact. So anything unusual about the waves here? Those at the back. Go on. Anything abnormal there? Will you treat this patient as MI? Do you all see any ST depression anywhere? Where is it? Bit of 1, AVL, V5, V6. I'll give you another clue. This patient's blood pressure is 200 over 110. What do you think this is? Anybody? Never mind. This is LVH. Makes sense, yeah. Okay, have a look. So what happens is you are looking, do you all know about the criteria how to diagnose LVH from ECG? If you get an echo, you can get a direct diagnosis, but from ECG, there's actually a criteria I will speak about. Yeah? So your LV voltages, that's what you look at. So the S wave over V2 or V1 and the R wave over V6, you plus everything together, you must get more than 7 boxes. So that will be 35 mm and above. So have a look at this again. So this is about 6, 7. This itself fulfills the criteria for LVH, right? Then add this together. More than 7 or not?
Yeah.
Yes? That's about 10 or 11, yeah? And you get this thing called LV stream pattern, left ventricular stream pattern. You all heard of this word before, right? Always. So that is the reason why you get your ST depression over your lateral leads. 1 AVL, V5, V6. This is not non-ST elevation MI or a STEMI as such. Okay? And you get your ST elevation V1, V3, you get a prominent U wave. Anybody came across this? Have a look at the ECG again. Can you see this? That's a T wave. Can you see a small wave over there? That is your U wave. Nampak tak? You all see or not? Yes. So these are the small things that you can see to see whether this is LVH, STEMI or non-ST elevation MI. So this is your criteria, Sokolov-Lyon criteria. Sounds fancy, but the thing is, the specificity of it is 100%. Amplitude. Your S wave in V1, V2, or R wave in V5 or V6 more than 35 mm, this is very, very suggestive of left ventricular hypertrophy. So have a look at this. LVH by voltage criteria. S wave in V2, R wave in V5 more than 35. Next one. The left ventricular stream pattern that I was speaking about. You all appreciate? Looks better now? You all can differentiate? Great. So, ventricular hypertrophy, the V in elevation. Next up, So, this is some cinnamon minda, just to wake you up a bit. You must spot the imposter. Is this the imposter? Or is this the imposter? You all agree. So 58 years old lady, another one, 58 years old lady came in with acute respiratory failure, sudden onset shortness of breath, came in, very stormy admission, intubated, respiratory stress, went to ICU, and you ask further histories from her. It seems that she has been having failure symptoms, orthopnea, PND, reduced effort tolerance for the past 1 month. So what do? ECG, it's an ECG masterclass today. Huh? So you do an ECG. So what do you see over here? Do you appreciate the Q wave? Over your V2, V3, V4, is mainly this three of this. Do you appreciate? Is there ST elevation anywhere? Is there ST elevation over here? God? God or cannot see? God. V2, V3, V4 is there. Patient, 1 month history of failure symptoms. This time came in, shortness of breath worsened, very, very acute. What do you think is going on with this patient? What happens is, when you have an ST elevation MI, your ST elevation will remain there for about 2 weeks. Okay? ST up will be there. Anything more than 2 weeks, you have to suspect of something else. The Q wave, of course, the area can be infarcted or very, very ischemic. Q wave will remain there. Your T wave will change. Your T wave either can become flattened or it become inverted. Okay? So, if this happens, patient presents to you, you must always suspect a thing called ventricular aneurysm. Rare, but we have seen many. So always suspect this, and you refer to the nearest cardiologist. So ECG features, I'll tell you something. So ST elevation, as I was saying, after 2 weeks, if there's still ST elevation, patient comes to you, stormy admission, think of ventricular aneurysm. And your ST elevation, you most of the time be over your precordial leads, not over your limb leads. It can be concave or convex, and most of the time you get a very, very well-formed Q wave. And so it's not important. Okay? So the survival of your aneurysm, basically if you go in for just medical therapy alone, about 50% of them will survive about 6.5 years. With adding your ACE, beta blocker, spironolactone, even with a heart transplant, they can go up to about 9 to 10 years. So that is the A in elevation, ventricular aneurysm. So there was a sleeping sickness that was described in Southeast Asia, most of the time in places like Thailand and also Vietnam. Quite interesting story actually. What happened is, very, very young men, when they were sleeping, they got up in the middle of the night, started shouting and just died. Not a laughing matter, but sounds funny. So this is actually known as Lai Tai in Thailand, where a young man was screamed in the middle of the night and suddenly died. So what happened is 1992, Brugada syndrome was actually, these Brugada brothers came up with this thing called Brugada syndrome, where patients had RBBB with persistent ST elevation, came in with a syncope and also a dysrhythmia. This is back in 1992. Modern days, men seem to scream at 2 things. One is when they see excessive makeup. Number 2, when their wives go shopping. Any married men here? Okay, good luck. So, Brugada syndrome is defined as ECG pattern with the symptoms. So you must have an ECG pattern and the symptoms of either syncope or sudden death. Most of them will actually come with sudden death. That's the problem. So most of the patients that I see, that I've seen in my experience before this, they come in with sudden death and eventually require an ICD, which might be helpful, but not in all the patients. Most of the time we have ICD. And they come in at the age of 25, 26, they're totally asymptomatic. 25, 26, they come in, they just drop it. So we must be able to catch them. So you get an ECG looking funny and you think it's Brugada syndrome, refer to cardiologist as soon as possible. So if seen in isolation, it's no more syndrome. This will just be called as a Brugada sign. So yeah, Brugada syndrome is the cause of 5% of sudden death cases, especially in young male. And this is because of sodium channel mutation, SCN5A. Another ECG, 21 years old, no known medical illness, came in with syncope, upon review as well. What is this? Have a look at the ECG. Anything abnormal here? Anybody? I just spoke about this, come on.
The inversion.
Brugada Type 1, Type 2, Type 3. If I go in depth, I don't think I'll finish my lecture today. So you go back and read Brugada so you know where to refer, okay? So, Thailand, T, or Brugada syndrome. It doesn't make sense, but you know Brugada. I told the story, right? I told the story so I can put in the elevation. Don't arm me like that, come on. Okay, so we got ELEVAT. So what is ion? Tremor, yes. So I for inflammation, pericarditis. Spoke about it just now, right? So you all would know lah. So have a look at this. ST elevation, widespread. The moment it's there, you must always think of pericarditis. And there are certain things that you don't see much. PR elevation that you can see in AVR. Can you see? Can you visualize? ST depression, and you have some ST elevation, which is quite widespread, and some PR depression over here. So, just remember 5 things, okay? So, diagnosis of acute MI as such is more preferred compared to your pericarditis if you have any ST depression, okay? Or if the ST elevation over lead 3 is more significant compared to the ST elevation in lead 2. In pericarditis, your ST segment elevation is more prominent over your inferior and high lateral leads. These are the points that you remember where you differentiate. So, in ST elevation MI, let's say it's inferior wall MI, you will always have reciprocal changes. Okay? So, inferior wall, you get reciprocal changes over your lateral leads. So, you get inferior wall, so you get ST elevation over inferior leads, you see reciprocal changes, ST depression over your 1 AVL, this is acute MI until proven otherwise. PR depression, rare. But if there's PR depression, you're thinking of viral acute pericarditis. And this PR depression will be in multiple leads. Number 5, I already spoke to you all about this, the ratio. Remember? The 0.25. So always remember that. If your ratio of your ST segment to T wave is more than 0.25, acute pericarditis is very, very likely. If it's less than 0.25, it is?
BR.
Thank you for listening. So, O is for Osborne waves, J wave. Have a look at this. This wave over here. Can you appreciate from the back? This is the biggest that can zoom already. There, this wave over here, you get a QRS, then you get a J wave, which is elevated. Okay? So, just want to, any of you actually watched the movie Frozen? I think all of you did, and more answers from the girls. So, in Frozen, okay, I didn't speak about Frozen. So what happened is, the reason why I put this up just now, just about half an hour ago, is because this guy called Osborne, in 1953, what he did was he started freezing dogs. Not freezing, he started cooling dogs. A bit dramatic. So he cooled them up to about 23 degrees Celsius. So Osborne, he noted there was a pattern of ECG which eventually went and progressed to VF arrest in these patients. So subsequently, then we noted that there was always this J wave which was there before all these catastrophic events happened. So these J waves, these so-called Osborne waves, because he discovered it, of course he will call it after him. So there are other differentials that you can see. It's either hypercalcemia, brain injury, or your vasospastic angina. So initially they thought this could just be a simple RBPP pattern with some J wave and all that. But the thing is, it's also related to your Brugada syndrome, and Brugada syndrome can lead to death. So when you see a J wave, it might not be benign after all. So take a thorough history and work up the patient even further and get more history, things like history of sudden death in the family and things like that. So this, I've been mentioning J point, J point, J point. So this is your J wave that I'm speaking about. J point, J point, J point. This is your J wave. We're almost done. So the N, the elevation, N, is non-arthrosclerotic vasospasm. Vasospastic angina. So it's the same. How you want to differentiate is the same but different morphology. Just that in vasospastic angina, you do not have any blockage in your vessels. So it's not because of your endoluminal plug rupture or intraluminal thrombosis as such. This is a total different mechanism, what we used to call as Prince-Metal angina. So most of the patients with Prince-Metal angina respond to and nitrates or your calcium channel blockers. So let's say they do not respond, you suspect this is pre-mental angina, vasospastic angina, they don't respond. So you must look hard on the other differential diagnosis of your ST elevation MI. So ED, most of the time they come with chest pain, ST elevation. If you don't know what to do, please refer the cardio team. Okay, it can be a bit confusing, so you will need help from your cardio counterparts. So I think I've elevated you all up by 8,000 square feet, 8,000 feet. Now, no? You all want to go through the slides again for number 1. So whenever you all think of